The endovenous laser is now at the saphenofemoral junction, and we keep an eye on that with the ultrasound. With this system we have quite a long introducer sheath, so holding the laser fibre exactly where it is, I withdraw the sheath back so there's only about 2 centimetres left inside. And what I always look here, we've got 2 sections here, 1, 2, 3, 4, so it's 4 centimetres back from the 2 mark, and that's going to allow me to calculate the length at the end. We want an LED of between 60 and 90 joules per centimetre, but this is a large vein, so we're going to go for 80 joules per centimetre, which is more than we'd do for a smaller vein. So we've set the laser up to supply us a little sound break every 8 seconds. So when I push this, provided every centimetre is 8 seconds and we're firing at 10 watts, that will give me my LED of 80. It's essential that you don't even start until you've planned your LED and made sure that all of your measurements are going to give you the LED you want for treatment. We're about to start treatment now, and if you watch on the ultrasound you'll see the effects of the laser immediately. Okay, patient, if you'd like to just tell us if there's any pain at all when we start. Now I always stop just after the first one, give a little tug, because you do sometimes the radial firing get a little bit of, the vein gets caught on the end. I just like to pull it off, and we're just going to do that again for the next centimetre. And again I can feel it caught there, so just a little tug and finish off that 2 seconds. So again we do it, usually by the 3rd centimetre there's no catching anymore. So just checking there's no catching there, so we can now just continue every centimetre at 8 seconds. And there's the break at 8 seconds. And this is a continuous pullback, trying to get it as smooth as possible, not just giving aliquots of energy at every centimetre. Very important to make sure that you get the correct LE dose at every centimetre of the vein. You don't want to undertreat a section of it and then overtreat another section, because of course it won't average out. It'll mean that you have a section that's likely to reopen and thrombose, and a section that may well be very tender. We always just make sure the patient is not experiencing any pain as we do this, just in case there are any bubbles going up any side branches, or just in case the tumescence isn't quite as thorough as we thought. But it is very, very rare. It's very, very rare for there to be a problem. Usually at this stage we can stop scanning, so Charlie's going to stop scanning there. As long as we know that the laser was up the correct vein and we've already checked that, and we know that the tumescence is fine, there's no reason to scan all the way down as we're doing this. With this system, which is very nice, we've actually got a very large black area for 2 centimetres, and when that appears we know that we are almost at the end. It's essential that you always know which cannula you're using, which introducers and which laser, so that you always get exactly the right length each time. If you know when the end of your fibre is going to appear on one sort of cannula, and then suddenly without telling you, your hospital or staff suddenly change cannulas, you might get into trouble, because you might end up either burning the end of the cannula if it's longer than you were thinking, or you might end up burning the skin if it was shorter than you were thinking. So it's very important to always use the same equipment, and if you change equipment, to spend some time looking at it outside of the body, so you know exactly where the end of the laser fibre is in conjunction with the end of your cannula when you're doing the pullback and you get near the end. It sounds simple, but it's amazing how many people do get into trouble when there's a sudden change, even if they're very experienced. There are automatic pullback devices. I've never used them myself because I like to vary the pullback depending on the size of the vein. For a small vein I might be doing 60 to 70 joules per centimetre, a medium vein 70 to 80, and then a large one like this with blowouts, or if it's got thrombus in it or anything else, I want to get right up to the 80 to 90 joules per centimetre. I'm sure that there are some very clever devices that do that automatically, but I always find that I can do it myself without needing those, with the expense of getting one in the first place and also the setup. I'm sure, however, there will be a time when they are cheap enough or advantageous enough that will change, but at the moment I've not seen such a device. So we're down to the 40 centimetre mark. And so we're just above the knee at this point. As we're doing this, what we'll do is we'll just ask the vascular technologist just to have a look at the vein in transverse section in the mid-thigh to see what it's been looking like at the immediate post-treatment stage. And we can see there that tiny little polo right in the middle. So what was a big vein initially with a big black lumen, of course it's all very, very small now, but it would be small in any case because it would be in spasm from having the tumescence put around it. But you can see there's little gas bubbles inside causing acoustic shadow, and that when it's being pushed on, when it's being pushed on, there's absolutely no give in the wall at all, so it's rock hard at the moment. And then in longitudinal section, you can see now there's gas bubbles within it, and the whole thing looks completely and utterly destroyed. So that's exactly what we'd expect to see at this stage. If there had been inadequate energy transfer, you still can quite often see at this stage the situation, you wouldn't have got a thrombus at the moment, so usually at this stage what you see is you see the vein still squishy. So if you haven't put enough energy in, so your LEED's been down in the 30s or 20s, which some systems have suggested, at this point it'll still be squishy. It may look good at 1 week because you'll have thrombus within it, but you can rest assured that at a year a lot of them would be reopened using those sorts of low energies. Every new device I've seen so far that has come out initially saying that you can use less energy per centimetre has had to revise itself, usually within a few years because of poor results. So there does seem to be a universal truth that for thermoablation you need to have, for a great venous vein, between 60 and 90 joules per centimetre. Less than 60, you don't get closure. You get thrombus, which then reopens in the longer term, so it may be reported as closure because of the thrombus, but you will only reopen when that thrombus resolves. When you come on to over 90, you're putting so much energy into it, you're starting to charcoalize the vein, and that causes an immense amount of pain. So we have seen people putting 120 joules per centimetre into veins, and those patients are usually in almost as much agony as the stripping. We're trying to coagulate this vein away rather than cause it to charcoalize or perforate. And here we can see on this system now, we've got the first centimetre of all black marking, and there's going to be a second centimetre showing me that I've only got 2 centimetres left at the end. So 2 more centimetres, and then the end of the fibre is going to be as close as I want it to the catheter. I'll show you that as we pull out. And about 1 centimetre there, and we're coming to the second centimetre, and at that point we're stopping. So we can see with 2 centimetres on for the black, the whole time I've been holding this cannula absolutely still with my right hand, as that's my measuring device. If I pull this out now from the skin, we can see that where the end is, it's about 1.5 centimetres on. So I know my system here, with the way I use it. 2 centimetres there gives me the right depth that I want on this side. Whichever system you use, as long as you know the relationship of this mark to this, you'll never burn the skin or have a problem.